Welcome to RSCH503, Research Methods and Biostatistics, a 3-credit graduate course offered by Drexel University College of Nursing and Health Professions. Outcomes research focuses on the end results of patient care, that is, the relationship between nursing interventions and patient outcomes. A key driver of outcomes research is the balance between quality of care and cost of care. Providers are increasingly being asked for outcomes data to justify costs of care. Likewise, demands are also being made of systems of care to document cost-effective quality patient outcomes. In 2015, the National Health Expenditure, or NHE, represented 17.8% of the U.S. economy, a significant percentage of our gross domestic product. How can high-quality, cost-effective patient outcomes be generated? Outcomes research focuses on this complex question. Outcomes research evolved from evaluation research. The theorist Avedis Donabedian proposed a theory of quality health care and the process of evaluating it. He published between 1976 and 2005. In 2005, he stated that quality of care is a remarkably difficult notion to define and is a reflection of the values and goals current in the medical care system and in the larger society of which it is a part. The World Health Organization defined quality of care in 2009 as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. While elusive to define, quality of care has become the subject of much scrutiny and research in the past 2 decades. The level and scope of concern or factors in the definition of quality care are noted in this figure from your textbook. The dimensions of this cube are health, subjects of care, and providers of care. Donabedian theorized that the dimensions of health, that is, physical, psychological function, and social function, are defined by the subjects of care, not by the providers of care, and are based on what consumers expect, want, or are willing to accept. Moving from the interior of the cube at the level of the individual to the exterior, where teams, systems of care, and coordination of care exist, is the complex and increasingly complex to define in terms of quality of care. The United States government has a history of involvement with the concept of quality of health care, noticed first with the establishment of the Agency for Healthcare Policy and Research in 1989, and subsequently to the evolution of the Agency for Healthcare Research and Quality, 1999. Evidence-based practice centers became a focus of the AHCPR, subsequently AHRQ in 1997, along with the establishment of the National Guideline Clearinghouse in 1998. The public's demand for accountability in health care has been integral to the increasing demand for outcomes research that demonstrates high-quality care at affordable cost. The American Recovery and Reinvestment Act of 2009 contains sections on evidence-based practice centers and effectiveness reviews. The demands for accountability have continued well into the 21st century. The Agency for Healthcare Research and Quality has now been designated as a scientific research agency. It is now the lead federal agency on quality of care research. It is responsible to coordinate all federal quality improvement efforts and health services research. The AHRQ disseminates evidence-based guidelines through the National Guideline Clearinghouse. You may wish to pursue the websites for both the AHRQ and the National Guideline Clearinghouse. Both contain invaluable information on outcomes research, as well as the process for generating evidence-based practice guidelines. In evaluation of the process of clinical care, there are several components to consider regarding evidence-based practice. First, consider standards of care. These are clinical guidelines, critical paths, and care maps that define standards of care for particular situations. Are such used in practice? Second, consider practice styles. Practice styles represent variations in how care is provided. Practice patterns represent variations in what care is provided. How and what must be considered in any practice setting. Lastly, consider the economic costs of care, prevention care, acute care, and others. What is the return on investment, or the ROI? Process components need to be understood and addressed in clinical settings. In evaluating the structures of clinical care, there are two important steps. First, what are the elements of structure, and how do these support evidence-based practice? These elements include the nature of organizational leadership, tolerance of innovativeness, organizational hierarchy, decision-making processes, distribution of power, financial management, and administrative decision-making processes. Second, evaluation of the impact of various structure elements on the processes of care and on outcomes. In evaluating structures, the unit of measurement is the structure itself. That is, for example, comparison of structures that provide primary care. As an example, an MD office versus a nursing center. Both the processes of clinical care and the structures that support clinical care can be examined via outcome research. In 1989, a large-scale study was conducted in the United States to examine factors influencing patient outcomes. This was called the Medical Outcomes Study. This study was designed to identify elements of physician care associated with favorable patient outcomes. The conceptual framework for the medical outcomes study included three areas of focus: structure of care, process of care, and outcomes of care. While the medical outcomes study failed to control for the effects of nursing interventions, staffing patterns, and nursing practice models on medical outcomes, it was a first such effort at outcomes research. Outcomes research provides nursing with robust study findings to enrich the foundation of nursing practice. Questions such as, how is nursing care organized in various types of organizations? How does nursing care in these environments influence patient outcomes? In 1994, the American Nursing Association, working in collaboration with colleagues, designed a plan to identify indicators of quality nursing practice and to collect and analyze data using these indicators throughout the country. These indicators were referred to as the ANA, Nursing Care Report Card. This report card was designed to be a standard to allow comparisons of hospitals in terms of quality nursing care. In 1998, the ANA funded the development of a national database to house data collected using nursing-specific quality indicators. This became the National Database of Nursing Quality Indicators, or the NDNQI. At present, the NDNQI has over 1,500 participating institutions. Participation in NDNQI meets requirements for the Magnet Recognition Program, and at least 20% of database members participate for this reason. The database is housed at the Midwest Research Institute, Kansas City, Missouri, and managed in partnership with the University of Kansas School of Nursing. There are currently 13 NDNQI. Examples include patient falls, physical restraints, and 11 others. Several other organizations are also involved in collection and analysis of quality nursing outcome indicators. These include the Collaborative Alliance for Nursing Outcomes Database Project, which is a statewide initiative, the National Quality Forum, the Veterans Affairs Nursing Outcomes Database, the Centers for Medicare and Medicaid Services Hospital Quality Initiative, the American Hospital Association, the Federation of American Hospitals, and others. Research on outcomes provided by advanced practice nurses, including midwives, nurse practitioners, clinical nurse specialists, and nurse anesthetists, is also ongoing. A major focus is the establishment of the relationship between advanced practice nursing interventions and patient outcomes. Outcomes currently in the APN classification include satisfaction with care delivered, symptom resolution or reduction, quality of life, and others. Advanced practice nurses are engaging in systematic reviews of empirical evidence on outcomes. Outcomes research methodologies link care received to results obtained, thus enabling better ways to monitor and improve quality. Focus is on samples and sampling plans, use of large databases, and diverse research strategies. For example, consensus knowledge building, population-based studies, practice pattern profiling, geographical analyses, prospective cohort studies, and retrospective cohort studies. One source of samples for outcomes research studies is large databases. Two broad categories of databases are available for patient care encounters. Clinical database, for example, from hospitals, HMOs, and other providers, and administrative databases, Centers for Medicaid and Medicare Services, health payers, etc. Such databases provide rich information from which to design outcomes studies. Economic studies in healthcare focus on efficiency, that is, determining the least expensive method of achieving a desired end while obtaining the maximum benefit from available resources. Economic evaluation is a set of formal, quantitative methods used to compare two or more treatments, programs, or strategies with respect to their resource use and their expected outcomes. A method employed in economic analysis is called cost-effective analysis, or CEA. Analyses used to compare different ways of accomplishing a clinical goal, for example, diagnosing a condition, or treating an illness, or providing a service. The alternative approaches are compared in terms of costs and benefits to identify the strategy that provides the most value for the money. Outcomes research employs statistical analyses to test for statistical significance of findings. The focus, however, is the clinical importance of study outcomes, the analysis of change in quality and outcomes over time, the analysis of improvement with selected interventions, the development of a standard or index of varying degrees of improvement with use of selected interventions over time, and the analysis of variance technique to track individual and group variance from a specific critical pathway are used to decrease preventable variance in the processes of care. The findings of outcomes research must be widely disseminated to all individuals and organizations that require knowledge of findings. Submit findings in oral presentations and written formats to organizations. Include dissemination via web, media, professional journals, and lay public. This presentation was prepared for graduate nursing students at Drexel University College of Nursing and Health Professions. The primary book used in this research is the Practice of Nursing Research and Appraisal, Synthesis, and Generation of Evidence, 2017 edition by Jennifer R. Gray, Susan K. Grove, and Suzanne Sutherland. This book is published by Elsevier Saunders, St. Louis, Missouri.